Okay, Jason, we're at threshold.
Wonderful. Thank you very much. Good morning and good afternoon and good evening if we have anyone that far out. Thank you for joining us for another ASAP webinar series. Today we'll be discussing gender equality and gender-based violence prevention. My name is Jason Porter. I'm a local partner strategy advisor in the Office of HIV/AIDS, and I will be giving you a few quick announcements before we turn it over to our speakers. So for a quick agenda today, just a few welcome and announcements from myself and from Catherine Brokenshire-Scott with ASAP. And then we'll turn it over for our gender equality and gender-based violence prevention presentation by Amelia Peltz and Emily Rittenauer with the Office of HIV/AIDS. But first, a few USAID announcements and updates for July. As you're all probably familiar, our SGAC COVID guidance continues to go out. This is guidance that is provided on a weekly basis by the Office of the Global AIDS Coordinator around guidance for PEPFAR programming in under COVID restrictions. And this is guidance that is released on Wednesdays and Fridays and then updated by the next week. So the latest release of updates is on July 15th, and this concerns hand hygiene and ARVs. Some updates on USAID's agency task force for COVID. So the agency also has a task force addressing more USAID wide programmatic issues. So the USAID task force recently collaborated with the USAID front office, our Office of Acquisitions and Assistance, and our Bureau for Policy Planning and Learning to host 3 calls with implementing partners. The topics for this included USAID's COVID-19 response, the America Acts campaign, and USAID's Over the Horizon efforts. Partners can find a copy of this presentation by clicking on this link, and again, these slides will be shared. The task force has also issued updated guidance regarding personal protective equipment and covered materials for implementing partners, as well as a set of frequently asked questions to help with any questions staff or implementing partners may have. The updated guidance includes additional information on how to make determinations under Exception 1 and Exception 2, more flexibility on regional procurement, and updates to redirection processes for PPE. And again, you should be able to click on the links to find these resources. So that's it. With that, I will turn it over to Catherine to continue with some ASAP notices.
Thank you, Jason. Welcome, everybody. We're so glad you could join. We had over 500 people register for this particular webinar, and we're hoping everybody is going to be able to join. I would like to do a couple of housekeeping announcements. First, we appreciate all your questions that you ask and request that you write them in the Q&A box at the bottom of your screen. And we'll have a time during the presentations where we pause and ask questions. We will then follow up by writing out all the questions, getting the answers, and sending all the Q&A out to participants. About 30 minutes before the end of the webinar, we'll launch a poll, and we would appreciate getting your feedback on this webinar. Again, I'd like to announce that we have 2,000 scholarships available for participants living in Africa, working with the NGO government. The scholarships are on financial management and compliance, COVID, there's a gender one, and there's a lot of M&E courses. We highly encourage your participation. And lastly, in response to your request, we have created a website where we can store all the webinar presentations, recordings, Q&A, and resources, and we will send you the link as soon as it is up and running. Thank you. I will now hand it over to Amelia Peltz, who will launch, oh, sorry, I forgot my next slide. Thank you, Jason. These are the upcoming webinars. The next one is July 29th on fraud, preventing whistleblower programs, detecting, reporting, investigating, and managing cases. This is a very important webinar. We found in all of our assessments with local partners, very few have strong systems in order to identify risks related to fraud and mitigating the situation. You see we have a lot of PEPFAR webinars coming up both in French and English. We have the fraud session in French, and then we'll have a PEPFAR expenditure reporting webinar, which is a repeat. So thank you. Now, this time I will be handing it over to Amelia Peltz to start the webinar on GBV, gender-based violence. Thank you.
Great. Thank you so much, Catherine. Good morning and good afternoon to you all. Thank you very much for joining us today. My name is Amelia Peltz, and I am the team lead and senior gender advisor of the Gender and Sexual Diversity branch in the Office of HIV/AIDS at USAID. I'm joined this morning by my colleague, Emily Reitenauer, a gender advisor on our team, and we're very pleased to welcome you today to our discussion on gender equality and gender-based violence prevention and response services in USAID's PEPFAR programs. Next slide, please. This is the agenda for our session today. We will start by covering some basic terminology that we use in USAID's PEPFAR programs to ensure we are all on the same page about the terminology we use, and then discuss the global prevalence of gender-based violence, as well as the relationship between gender-based violence and HIV outcomes. The next section of the presentation will focus on USAID and US government policies on gender and gender-based violence, and then specifically USAID's gender and GBV technical priorities for PEPFAR programs. We will then cover some basic information on the PEPFAR monitoring, evaluation, and reporting indicator, or MER indicator, as is commonly used, that we use to track progress in one aspect of our GBV programming. We will then discuss some emerging issues with COVID-19 and gender-based violence, which will feature one of our local partners in Zambia, ZCCP. We will then conclude the presentation by sharing some additional technical resources and covering any additional questions that you may have. Next slide, please. So to start, we will cover some basic terminology that we use in our gender equality and gender-based violence programs. Next slide, please. So you'll see 4 definitions here on the slide, and I will go through each of them one at a time. Sex is the classification of people as male or female. At birth, infants are assigned a sex based on a combination of bodily characteristics, including chromosomes, hormones, internal reproductive organs, and genitalia. Typically, when a mother delivers a baby, the baby is assigned a sex based solely on the baby's visible genitalia. However, biological sex is much more complicated than just someone's genitalia. Biological sex includes a person's chromosomal, hormonal, and anatomical characteristics. The next definition that we use frequently is gender. Gender is the socially defined set of roles, rights, responsibilities, entitlements, and obligations of females and males in society. The social definitions of what it means to be a female or a male can vary among cultures and also change over time. This is how society sets the boundaries of what is considered acceptable or proper for men and women, boys and girls. The next definition is gender identity, and this is a person's deeply felt internal and individual experience of gender, which may or may not correspond with the sex assigned at birth. Gender identity is how a person understands their own gender. It is deeply felt and can remain private. The formation of gender identity is influenced by hormones, environment, biological sex, culture, class, and other personal circumstances. Being born biologically one way, but then identifying another way, for example, someone who is biologically female but who identifies as a man, may cause distress in places with rigid gender norms or hostility towards gender nonconformity. The final definition on this slide I wanted to cover is sexual orientation, which is an enduring pattern of romantic or sexual attraction, or a combination of these, to another person. These inherent attractions are generally subsumed under heterosexuality, homosexuality, bisexuality, or asexuality. Sexual orientation is about emotional, romantic, and sexual attraction. Everyone has a sexual orientation, and this exists along a continuum. Gender identity and sexual orientation are important to understand because individuals can often be discriminated against if they are perceived to transgress society's norms. Next slide, please. So this friendly character, whom we call the gender person, demonstrates 4 key dimensions of a human being in relation to gender and sexuality: biological sex, gender expression, gender identity, and sexual orientation. And it can be a really helpful way of remembering the definitions that we covered on the previous slide. Next slide, please. The next definition we will cover is gender-based violence. Gender-based violence, or GBV, is an umbrella term, meaning an all-encompassing term for any harmful threat or act directed at an individual or group based on actual or perceived biological sex, gender identity or expression, sexual orientation, or lack of adherence to varying socially constructed norms around masculinity and femininity. So that's a long sentence. What does it actually mean in the real world? It means that GBV is rooted in structural gender inequalities, patriarchy, and power imbalances that we see in our society every single day. GBV is characterized by the use or threat of physical, psychological, sexual, economic, legal, political, social, and other forms of control or abuse. GBV impacts individuals across the life course and has indirect and direct costs to families, communities, economies, and global public health and development. Next slide, please. So now that we have covered the basic terminology that we use in our gender equality and GBV programs, we will review some data around the global prevalence of gender-based violence. Next slide. So first, let's start with a pop quiz. What is the global prevalence of violence against women? Is it A, 1 in 10 women will experience physical and/or sexual violence from a partner or sexual violence from a non-partner? Is it B, 1 in 5 women? Or is it C, 1 in 3 women? Feel free to type your answer into the Q&A box. Okay, I see lots of good responses here. A lot of people are saying C. Some people are saying B. Let's go to the next slide and find the answer. So the answer is C. 1 in 3 women will experience physical and/or sexual violence from a partner or sexual violence from a non-partner over the course of their lifetime. Next slide, please. So this is a graphic from the World Health Organization that shows the lifetime prevalence of violence against women across different regions globally. It's important to note here that regional estimates can mask important national and subnational estimates, which are often higher than the regional estimate. In addition, certain population subgroups may be at higher risk, such as pregnant women, women living with HIV, women with disabilities, Indigenous women, and women who engage in sex work. Next slide, please. This is a graphic, again from the World Health Organization, that illustrates the different types of violence women may experience in their lifetime. In USAID's PEPFAR programs, we are primarily focused on intimate partner violence, non-partner sexual violence, and violence against children because of the proximate link to HIV acquisition. Next slide, please. Now, if someone were to say to you, only women experience gender-based violence, would you say yes or no? Again, feel free to type your answer into the chat box. Okay, I see a lot of people saying no. Next slide, please. That is correct. The answer is no. Unfortunately, gender-based violence is also experienced by children and adolescents, both girls and boys, as well as by key populations, which include men who have sex with men, sex workers, people who inject drugs, transgender individuals, and people living in closed settings, such as prisons. Next slide, please. So focusing now on some of the data around violence against children. This is a graphic that illustrates the prevalence of violence against girls and boys across a selection of countries where the Violence Against Children survey has been conducted. The Violence Against Children surveys, or the VACS surveys as they are known, are important sources of data on violence against children, especially because they cover both boys and girls. Next slide, please. This is more data that was collected through the VACS surveys. And this data has also shown us that even when young survivors disclose their experience of violence, they rarely seek or receive services, including post-rape care. And this is really important for the work that we do, because reaching survivors of violence with timely services is essential. Next slide, please. This is another graphic from the USAID-funded Linkages project, which highlights both the type and frequency of violence against key populations globally. As the map notes, violence against key populations is prevalent, frequent, and often severe. Next slide, please. Gender-based violence is experienced throughout a person's life. And this is a graphic that illustrates how it manifests itself across the life course and the impacts that it may have at different stages of a person's life, starting from pre-birth up through infancy, childhood, adolescence, and into reproductive age or as adults, all the way into an elderly person's life. Next slide, please. So another yes or no question. While gender-based violence is a human rights violation, it does not impact HIV outcomes. Again, feel free to type your answers into the chat box. Okay, you see many people are responding no. Can we go to the next slide, please? Yes, the answer is no, and our next set of slides will explain why this is the case. So now we're going to cover the relationship between gender-based violence and HIV outcomes. Next slide, please. So how do you think gender-based violence impacts HIV outcomes? Again, feel free to type into the chat box any ideas that you may have. Okay, we can move on to the next slide. Sexual violence, yes. We can move on to the next slide. Great, thank you. So this is some important data that we're going to cover that talks about the relationship between HIV, violence, and gender inequality. As has been very well documented, gender inequality and gender-based violence are some of the most critical barriers to reaching HIV epidemic control. As we saw in earlier data, globally, 35% of women experience intimate partner violence or non-partner sexual violence in their lifetime. And women who experience intimate partner violence are 1.5 times more likely to acquire HIV. The experience of gender-based violence, particularly intimate partner violence, is associated with lower use of antiretroviral treatment, half the odds of self-reported ART adherence, and significantly worsened viral suppression among women. Intimate partner violence has also been found to lower adherence to pre-exposure prophylaxis, or PrEP. So in short, violence poses a substantial barrier to the effectiveness of HIV services and can undermine the uptake of and adherence to proven biomedical prevention and treatment options. Next slide, please. So as we have shown, gender-based violence poses a significant barrier to our efforts to achieve HIV epidemic control. Throughout this presentation so far, we have seen how GBV is both a cause and a consequence of HIV. In other words, GBV and HIV are mutually reinforcing epidemics. As such, preventing and responding to gender-based violence is essential to meeting PEPFAR's 95-95-95 goals. So this graphic that you see on the screen illustrates how GBV impacts each phase of the HIV clinical cascade and underscores the importance of addressing both HIV and GBV epidemics concurrently. Next slide. So there's a lot here on this screen. This is a graphic produced by the STRIVE Consortium that illustrates the pathways between intimate partner violence and HIV risk. Contrary to popular belief, sexual violence appears not to be the main factor explaining the association between violence and HIV at a population level. Although individual women can become infected with HIV through rape and forced sex, a number of indirect pathways appear to be more significant. One pathway is sexual abuse in childhood, which sets up a cascade of developmental and psychological consequences that can lead to a range of risk behaviors, such as earlier sexual debut, more sexual partners, and substance abuse, that increases a woman's risk both of acquiring HIV and of being re-victimized by violence in adulthood. A second important factor is the HIV status of a woman's sexual partners. It is now clear that men and boys who abuse women and girls are themselves more likely to be HIV positive, which in turn increases the risk of HIV acquisition among their partners. Men who are violent are also more likely to engage in a range of risk behaviors, including having outside sexual partners, abusing alcohol and other substances, engaging in anal sex, and visiting sex workers. Finally, emerging evidence also suggests that violence and trauma have a biological effect on immune and hormonal functions believed to be important in potentially increasing HIV acquisition and disease progression. Thus, women living in abusive relationships or violent settings may be biologically more at risk of acquiring HIV and possibly of HIV progressing more rapidly. Next slide, please. This graphic from the World Health Organization illustrates some of these adverse health outcomes among women experiencing gender-based violence, including an increased likelihood of experiencing depression, increased risk for HIV, as well as the risk of serious injury and death. Next slide, please. So we will now pause here for a few moments and take time for some questions.
We have one question. Does the data on GBV cover areas with conflicts or not?
So the data that Yes, thank you. Thank you. Sorry, I was getting a bit of feedback. So the data that we presented primarily comes from the World Health Organization's multi-country study of violence against women. We've also looked at data from the violence against children surveys. Those cover a range of countries, some of which may have experienced conflict. There are other studies that have looked specifically at the prevalence and types of violence in conflict-related settings, but I'm not sure if they specifically looked at HIV, violence, and conflict-related settings. And so those would be some separate studies that would be worth looking at, including the demographic and health surveys, looking at issues of violence in conflict situations. So I would recommend looking at the demographic and health surveys, the WHO multi-country survey, the violence against children survey, and any other surveys that were done by UNFPA as well have also collected this data. And those would all be very good sources of data on the prevalence of violence in conflict settings.
That's the only question we had.
Okay, if that's the only question we have at this time, I will now turn the next section of our presentation over to my colleague, Emily Reitenauer.
Thank you, Amelia. Hello, everyone. As Amelia mentioned, my name is Emily Reitenauer. We'd like to now take a moment to review our U.S. government and USAID policies and strategies in promoting gender equality and addressing gender-based violence. Using a two-pronged approach, USAID's PEPFAR-funded gender and GBV activities advance three key strategy and policy documents: the PEPFAR Gender Strategy, the USAID Gender Equality and Female Empowerment Policy, and the U.S. Government Strategy to Prevent and Respond to Gender-Based Violence globally. The two-pronged approach USAID uses to advance these three key strategy and policy documents includes: 1, integrating gender and GBV considerations into facility and community-based HIV prevention, testing, and care and treatment programming. And 2, focusing on standalone priority areas, such as preventing and responding to gender-based violence, including violence against children and activities to address gender and social norms that impact HIV outcomes. These three strategy and policy documents provide the foundation for USAID's two-pronged approach, guiding our work in addressing gender inequality and gender-based violence, which, as discussed, are two significant barriers to epidemic control within USAID PEPFAR programs. Now let's discuss how we address gender inequality and GBV within USAID's PEPFAR programs. Gender inequality and GBV impact each element of the clinical cascade and impede the effectiveness and success of USAID's PEPFAR programs. As such, preventing and responding to gender inequality and gender-based violence are essential to meeting PEPFAR's 95-95-95 goals. In the same way we perceive the clinical cascade, we also perceive GBV prevention, case identification, and response as a cascade, focusing on improving HIV prevention, testing, and treatment outcomes. While there are many different kinds of gender-based violence, as Amelia mentioned, PEPFAR is primarily focused on intimate partner violence, non-partner sexual violence, and violence against children because of the proximate relationship to HIV. There are 4 key gender and GBV technical priorities for USAID PEPFAR programs to address gender inequality and gender-based violence. The first priority is addressing intimate partner violence, or IPV, in PrEP, index testing, and care and treatment services through GBV case identification, specifically clinical and routine inquiry for violence. The second priority is integrating post-violence clinical care services into care and treatment sites. The third priority is improving linkages between community-based HIV and GBV prevention interventions and clinical post-violence care services. And the fourth and final technical priority is improving monitoring of GBV case identification, prevention, and response activities. Let's now review these technical priorities in a bit more depth. The first technical priority involves addressing intimate partner violence in PrEP, index testing, and care and treatment services. For this technical priority, all USAID PEPFAR sites delivering PrEP, HIV index testing, and care and treatment services must conduct GBV case identification. We recommend that clinical inquiry for intimate partner violence be the method used to identify survivors of violence in PrEP, index testing, and care and treatment services. Clinical inquiry is a method of GBV case identification whereby providers are trained to identify signs and symptoms of violence and only ask clients who exhibit these signs and symptoms about their experience of violence. When providers identify someone who has been experiencing violence, they provide first-line support and provide and/or refer the survivor to GBV response services. So that is clinical inquiry, which is recommended for PrEP, index testing, and care and treatment. We understand, though, that it is not always feasible to implement clinical inquiry within PrEP and index testing services. We also know that many PrEP and index testing providers are not trained on identifying signs and symptoms of violence. Therefore, if clinical inquiry cannot be implemented within PrEP and index testing services, we strongly recommend that routine inquiry for intimate partner violence be implemented instead. Routine inquiry for intimate partner violence is a method of GBV case identification whereby providers ask all clients who present for specific services, in this case, only PrEP and HIV index testing services, about experience of violence. When providers identify someone who has experienced violence, they provide first-line support and provide and/or refer the survivor to GBV response services. So to summarize, clinical inquiry is recommended for PrEP, index testing, and care and treatment. But if clinical inquiry cannot be implemented in PrEP and index testing services, then routine inquiry should be implemented instead. While this approach is grounded in WHO guidance, one important distinction to note is that USAID's recommendation of a hybrid approach using both clinical and routine inquiry in our HIV programs is different from WHO's approach, which recommends that only clinical inquiry be used. USAID's decision to recommend the use of both clinical and routine inquiry is informed by WHO clinical and policy guidance, which states that routine inquiry may be considered in the context of HIV testing and counseling, as well as when assessing conditions that may be caused or complicated by intimate partner violence, such as HIV. Additionally, as mentioned, we understand that not every USAID PEPFAR site that is required to ask about violence will be able to use a clinical inquiry approach, such as HIV index testing sites conducting IPV risk assessments. So while clinical inquiry is strongly recommended in USAID's PEPFAR programs, particularly in HIV and care and treatment services. We also support our implementing partners and HIV service delivery sites to conduct routine inquiry, but only when the minimum requirements to do so can be adhered to. We'll now review what those minimum requirements are. The 6 requirements that sites must meet in order to ask about experience of violence are as follows. 1, providers must be trained on and offer first-line support using the lives approach to all individuals who disclose experience of violence or to individuals who providers suspect are experiencing violence. We'll talk a little bit more about this first requirement in a moment. The second requirement is that there must be a protocol or standard operating procedure established for asking about and responding to experience or fear of violence, including providing first-line support and referrals. The third requirement is that providers must be trained on and use a standard set of questions to ask about experience or fear of violence. Providers should be able to document responses to these questions on that form. The fourth requirement is that providers must be trained on how to ask about and or identify signs and symptoms of violence. The fifth requirement is that providers must only ask about violence in a private setting, always ensuring that they are maintaining the confidentiality of the client. And lastly, sites must have an established process for offering referrals or linkages to other local GBV response services. So these are the 6 minimum requirements that sites must meet in order to ask about experience of violence. Before we move on to discuss the second technical priority for gender and GBV in USAID's HIV programs, we'd like to take a moment to discuss this first minimum requirement listed here, that the provider must be trained on and offer first-line support using the lives approach. The provision of first-line support is a critical component of GBV case identification. It can often be the most important care a survivor receives and significantly impact their willingness and ability to access GBV response services, which can impact their HIV outcomes. First-line support is the immediate care given to a survivor of gender-based violence upon first contact with the health or criminal justice system. WHO developed a helpful mnemonic called LIVES, and in USAID's PEPFAR programs, we often refer to first-line support as LIVES. Within LIVES, the L stands for listen. This means listen closely to the survivor with empathy and do not judge them. The I stands for inquire. This means assessing and responding to the survivor's emotional, physical, social, and practical needs and concerns. The V stands for validate. This means that when someone discloses that they have experienced violence, the provider shows that they believe and understand the survivor. The E stands for ensure safety. It is important to discuss how to protect the survivor from further harm. And lastly, the S stands for support, which involves helping the survivor connect to services and other forms of social support through referrals. Again, first-line support, or lives, is the immediate care given to a survivor when they disclose experience of violence. As mentioned, responding inappropriately to a survivor who has disclosed experience of violence can greatly impact their willingness and ability to access GBV response services, which can impact their HIV outcomes. All providers who ask clients about experience of violence, either through routine or clinical inquiry, must be trained on the provision of first-line support. Moving on, The second gender and GBV technical priority for USAID's PEPFAR programs is integrating post-violence clinical care services into care and treatment sites. USAID has primarily two models of service delivery for post-violence clinical care services. The first listed here are standalone sites, which are often referred to as GBV one-stop centers. The second model of service delivery is through integrated sites, which is where post-violence clinical care services are provided at care and treatment sites. So clinical GBV response services are provided at sites with care and treatment targets. Our goal is to ensure that all USAID care and treatment sites that can provide the full minimum package of post-violence clinical care services also provide clinical GBV response services and have GEN-GBV targets. We'll discuss GEN-GBV and the minimum package of post-violence clinical care services in a moment. Countries are encouraged to focus on expanding GBV response services at integrated sites, as well as strengthen linkages to the HIV clinical cascade at standalone GBV sites or one-stop centers. The third priority is improving linkages between community-based HIV and GBV prevention interventions and clinical post-violence care services. In non-clinical community-based interventions, individuals should only be asked about violence when assessing their HIV risk or vulnerability for the purposes of enrolling into DREAMS or OVC programming. Individuals found to have experienced or be experiencing violence should be provided with first-line support using the LIVES approach and actively referred to post-violence clinical care services. Additionally, individuals who present at facilities for post-violence clinical care services should be referred to community-based HIV and GBV prevention programs as appropriate, such as DREAMS, OVC, and community-based key populations interventions. The fourth and final technical priority is improving monitoring of GBV case identification, prevention, and response activities. This includes ensuring correct reporting on the GBV indicator, as well as using custom gender and GBV indicators and disaggregates to measure GBV case identification, prevention, and response activities, as well as gender norms change activities. So I have a question for you all. What is the PEPFAR indicator that captures the number of people who receive post-violence clinical care services? Hint, I mentioned it just a few moments ago, but what is the name of that indicator? Please type your responses in the chat box. Someone says GEN-GBV. Do others agree, or do you GEN-GBV again? Gender GBV, GEN-GBV, GEN-GBV. You're all experts. That's great. Yes, it's GEN-GBV. This is the one and only indicator that captures PEPFAR GBV response programming. We're now going to review the GEN-GBV indicator before taking a moment for questions. GEN-GBV measures program performance for PEPFAR-supported post-violence clinical care services. This indicator captures the number of individuals who have received post-violence clinical care services based on the minimum package. The minimum package of post-violence clinical care services, as defined by WHO and PEPFAR, and as articulated in the GEN-GBV indicator reference sheet in the PEPFAR indicator reference guide, includes treatment of injuries, rapid HIV testing, post-exposure prophylaxis or PEP, emergency contraception, STI testing, screening, and treatment, counseling, And by counseling, we mean first-line support using the LIVES approach, and referrals to other local GBV response services as necessary, including longer-term psychosocial support, shelter services, police, legal, child protection services, economic empowerment activities, etc. As mentioned on the right of the screen, post-exposure prophylaxis, or PEP, should be offered if a client presents for services within 72 hours of experiencing sexual violence. How many days is 72 hours? Type in the chat box. How many days is 72 hours? Is it 5 days, 7, 2 days? How many days? 3, 3, 3? Yes, 3 days. So a client should be offered post-exposure prophylaxis if they experience sexual violence and present within 3 days. Additionally, as mentioned on this slide, emergency contraception should be offered if a client presents for services within 120 hours of experiencing sexual violence. How many days is 120 hours? Please type in the chat box. How many days is 120 hours? 5. 5, 5, 5. Great. Yes, you're all excellent at math. Yes, fantastic. So a survivor should be offered, if that survivor is a biological female, should be offered emergency contraception within 5 days, within 120 hours of experiencing sexual violence. All of the services listed here in the minimum package, which on this slide are separated into services for physical/emotional violence, and then additional services for experiencing sexual violence. All of these services must be in place at a site for that site to report on GEN-GBV. Therefore, if there are sites that do not or cannot offer all of the services listed here, those sites should not have GEN-GBV targets, nor should they report on GEN-GBV. With that being said, a client does not need to receive all of these services to be counted under GEN-GBV. These services should just be offered to the client as appropriate. For example, if a client presents for post-violence clinical care services 11 days after experiencing sexual violence, that client will not be eligible for PEP and should therefore not be offered PEP, or emergency contraception, but should be offered the other services in the minimum package and be counted under GEN-GBV. If that client is offered the other services in the minimum package and only accepts some of those services, that client can still be counted under GEN-GBV, okay? So a client does not need to receive all of these services to be counted under GEN-GBV. They just need to be offered to the client as appropriate, and the client must receive at least one to be counted under GEN-GBV. Understanding what is included under GEN-GBV is as important as understanding what is not included under GEN-GBV. GEN-GBV is a clinical indicator. It captures the provision of clinical GBV response services. It does not capture community-based GBV prevention activities, nor does it capture non-clinical GBV response activities, such as case management, shelter services, education, couples counseling, etc. It does not capture community-based gender norms change activities as well. Although these activities and services are not captured under GEN-GBV, they are critical to GBV prevention and response and supporting the survivors of violence to have improved HIV outcomes. Therefore, we encourage the use of custom indicators to capture this important work. These custom indicators can be reported into datum through indicator narratives. There are several ways in which GEN-GBV results are disaggregated. When reporting on GEN-GBV, sites should report the sex of the clients, reporting both females and males served, the age of the clients, using finer age bands, the type of violence, either sexual violence or physical/emotional violence, and the completion of post-exposure prophylaxis, or PEP. For the type of violence disaggregate, please note that the PEPFAR MER guidance prioritizes reporting of sexual violence over physical/emotional violence. We know that individuals may be experiencing different types of violence, but to avoid double counting, if a client experiences both sexual violence and physical or emotional violence, that client should only be counted under the sexual violence disaggregate when reporting on GEN-GBV. And for the PEP disaggregate, a client should only be counted under the PEP disaggregate if the client completed a full course of PEP, which is typically 28 days. If a client is not eligible for, chooses not to take, or does not complete PEP because of default or loss to follow-up, the client can still be counted under GEN-GBV, but should not be counted under the PEP disaggregate. Some final points about GEN-GBV. This is an annual indicator, meaning it is reported into datum once a year during the fourth quarter. Ideally, implementing partners report their GEN-GBV data to USAID country teams more regularly, either monthly or quarterly. We encourage implementing partners to analyze their GEN-GBV data regularly and use it to identify successes and potential challenges in order to enhance and improve program performance. Are there any questions about what we've just reviewed? If so, please type your questions in the Q&A box.
Thank you. I have a first question. Elaborate more on demarcating line between GBV as an umbrella term and VAC. And a sort of related question, where were VAC surveys conducted? And what's the experience with violence in schools and anything to address the challenge?
Sure. Amelia, would you like to cover that one or should I respond?
Feel free to go ahead and respond, that's fine, and I can always jump in after.
Okay, great. So violence against children is violence against children. So that is violence that children experience, which can include neglect, it can include sexual abuse, any violence that is perpetrated against a child. Gender-based violence is an umbrella term that often encompasses violence against children, but gender-based violence is violence that is perpetrated against an individual because of their sex, because of their gender identity, because of their gender expression, because of their sexual orientation. It can impact children, it can impact adults, and it is something that is much broader. Again, GBV is an umbrella term. So there are often forms of violence against children that fall within gender-based violence. So that is the way in which GBV is related to violence against children. Services for violence against children. There are clinical and non-clinical services for violence against children. It's important to note, though, that the services that are available for children, or I should note that children require it's a unique set of considerations when working with children. And the services, although many of the principles in providing services to adults apply to working with children, there are other things that need to be kept in mind when providing services to children, such as child protection, such as mandatory reporting laws. WHO has different sets of clinical guidelines for providing services to adult women who experience intimate partner violence and sexual violence, and then providing clinical services to children who identify or who experience sexual abuse and neglect. There are many of the sites that provide clinical services to adults also provide clinical services to children, but it's also important to remember that there are many distinct and unique considerations that providers need to keep in mind when providing clinical services to children.
Thank you. Another question, do we have data on violence against men? And somewhat related, why leave clinical inquiry during VMMC service reception?
Sure. So we have limited data on violence against men. We have much more data on experience of violence against women and violence against children. We do know that men experience violence. With that being said, when it comes to gender-based violence, we know more often than not that women experience gender-based violence at very high rates in many countries around the world, including the United States. We also know that children, both boys and girls, experience high levels of gender-based violence. We do have some data on violence against different groups of key populations, including men who have sex with men, including trans women and trans men, as Amelia had reviewed in the beginning. But our data that is available for violence against men is quite limited. However, in our programs, we really focus on violence against adult women, violence against children, that includes girls and boys, violence against adolescent girls and young women, and then collaborating with our key populations colleagues on violence against KP, just because we know, based on all of the available evidence, about how violence can significantly impact HIV outcomes for these particular populations.
Thank you. The next question, do we have standardized PEPFAR training packages for lives? And somewhat related, why does PEPFAR not support treatment for injuries, STI treatment for survivors?
Sure. So WHO released a training at the end of last year on caring for women who have been subjected to gender-based violence, or excuse me, who have been subjected to violence. And this is a training on the provision of first-line support or lives. Within USAID headquarters at the Office of HIV/AIDS, Amelia and myself, we have adapted that training, that WHO training, for USAID PEPFAR programs, and we are actually rolling out that training currently. It is focused on on GBV case identification, so clinical and routine inquiry, as well as the provision of first-line support using the lives approach within USAID's PEPFAR programs. That is something we're working on right now. With that being said, again, a great resource is the WHO training that was released. That training, the curriculum, and the materials and the PowerPoint presentations are all available online on WHO's website. It is also my understanding that WHO will be in the future releasing a computer-based version of that website of that training that can be taken online. But we on our team are currently rolling out a training of trainers for first-line support lives in USAID PEPFAR programs. And once we finish this first round, we will work with our country teams on cascading that training down to more of our partners, sub-partners, and providers.
Thank you. Can you please explain the best way of providing first-line support to a child?
Sure. Oh, one question, sorry. Why leave out clinical routine inquiry during VMMC service reception?
Yes.
So yes, we are really focused again on adolescent girls and young women, key populations, children, boys and girls, and adult women. And within that, we're really focused on PrEP and index testing. But more importantly, we have evidence, and there's a lot of evidence around the impact of violence on PrEP adherence, as well as the impact of violence or the experience of violence as an adverse event in relation to partner notification services within HIV index testing. And because of that evidence that we have really focused our efforts on PrEP and HIV index testing and partner notification services. So that's really why we focus on those two interventions, as well as care and treatment services, rather than VMMC. And I'm sorry, can you repeat the other question?
Sure. Can you please explain the best way of providing first-line support to a child?
Sure. So I will say that, again, I'm going to plug again the WHO clinical guidelines for responding to children and adolescents who have experienced sexual abuse is really fabulous, and it contains some pointers and some things that need to be kept in mind when providing first-line support to children. Additionally, for children, the Organization for Children developed a training on identifying violence against children and providing first-line support to children. So those are also great resources. Many of the principles of providing first-line support to adults, including the LIVES approach, are applicable to providing first-line support to children and adolescents. Again, the only difference is that there are key considerations when working with children, when communicating with children, when interacting with children. There are also legal and policy considerations that need to be kept in mind as well, such as I mentioned, mandatory reporting, and also adhering to child protection guidelines and things like that. Yes.
Oh, maybe we take the last question, and then we'll take the remaining questions at the end of the presentation. So the last question, you said GEN-GBV is annually reported. How do we take care of that who experienced abuse twice or more during the reported period?
Sure.
And also a related question, what is GEN-GBV?
So GEN-GBV, I'm gonna go back to that slide. So GEN-GBV is the number of people receiving post-GBV clinical care based on the minimum package. Every time an individual, I have a response for the question about if a person presents for services twice. But before I respond, I would like to confirm with my SI colleagues, as this is a large audience. So that is something that, if it's okay, we can send out a response to that later, just so that I can confirm if that's all right. And I also noticed someone mentioned that I didn't write down why doesn't PEPFAR provide support, or excuse me, why doesn't PEPFAR support treatment of physical injuries and STI testing, screening, treatment for survivors? Thank you for bringing that up. There are certain things within the minimum package that PEPFAR does not fund. One of those things is often STI testing, screening, and treatment, and another is emergency contraception. These are things that PEPFAR does not fund. It is currently just not within their mandate. So these are things that need to be funded from other sources, whether they are the government, whether it's from UN bodies or other donors. But PEPFAR does not fund, generally speaking, STI testing, screening, and treatment, and emergency contraception. But we are happy to answer the remaining questions at the end of the webinar, or to also type responses and send those out to all participants later.
Thank you.
Sure. So at this point in time, I'm going to hand over to Amelia to discuss GBV and COVID-19.
Great, thanks so much, Emily. So as Emily noted, we'll now spend a little bit of time discussing some of the impacts of COVID-19 on gender-based violence, and also hear from one of our partners in Zambia. Next slide, please. So for the past several months, we have been seeing a lot of reports on increases in domestic and intimate partner violence, which sadly is very common and well documented during times of crisis and instability and uncertainty. We're particularly concerned with how these increased reports of violence are affecting people living with HIV and those who are facing a multitude of risks, including adolescent girls and young women, as well as key populations. What we know right now is that survivors are unable or have great difficulty in seeking timely post-rape care at health facilities or one-stop centers. We know that they are unable to leave dangerous situations or access any kind of in-person group-based support or counseling. In addition, missed routine healthcare or social service appointments because of some of the physical distancing requirements that many countries have implemented mean there are fewer opportunities to identify survivors and get them the help that they need. Next slide, please. So what this means right now is that we need to adapt our programs using a range of solutions that meet the needs of all survivors. Now, this may include using mobile and online technologies to provide counseling and safety planning. It means employing low-tech options to reach individuals who do not have access to or control over their own mobile phone or internet connection, and finding safe and innovative ways to reach the most vulnerable and isolated in the community. Next slide, please. We also need to think about and implement solutions to help health and social service providers adapt their service delivery methods, particularly counseling and safety planning, and to support to cope with and manage increased stress and trauma. Next slide, please. So as we mentioned earlier, we are very fortunate today to have our partner, the Zambia Center for Communication Programs, with us today to talk about some of the work that they are doing under the Stop GBV project to address the impacts of COVID-19 on GBV. So I'm very pleased to introduce Doreen Manda, the Deputy Chief of Party from ZCCP, who will now provide us with some brief remarks. Doreen, over to you.
Thank you very much. Hello, everyone. My name is Doreen Manda. I'm the Deputy Chief of Party for the USAID Stop GBV project that is implemented by Zambia Center for Communication Programs. I will try to be as brief as I can, but before I go into the presentation, allow me to just provide a brief context of ZCCP and the USAID Stop GBV project. So ZCCP is a local NGO established in 2002 and is specialized in social and behavior change communication. We are a prime and working with 2 subs, and we have presence in 8 of the 10 provinces of Zambia, but in selected districts. We are in a 2nd year of implementation, and the project will run for 5 years. The goal of the USAID Stop GBV project is to strengthen the environment for target population, that's the girls and women, the boys and men, and members of the key and priority populations, including persons living with disabilities, to live lives free of gender-based violence. And our focus target are children 9 to 14 years, adolescent girls and young women, adolescent boys and young men, and the circle of influence, while we work with government ministries, traditional and religious leaders. So the USAID Stop GBV project has got mainly 3 components. So there's a prevention, survivor support, and access to justice component. And all these components have been greatly affected by COVID-19. Now I'm moving to the main presentation, and I'm going to be talking about 3 key areas. So we can move to the next slide, please. Thank you very much. So we're going to be, I'm going to discuss the impact and challenges of COVID-19 on our ability to reach people and deliver services. I'm going to talk also about the programmatic solutions to the challenges first in the context of COVID-19. And I will also talk about how we are tracking and monitoring these programmatic shifts. So here, this slide, we just seeing how the program was being implemented before COVID. As you can see in the picture, there is a group, a dialogue, a small group discussion that is going on. And it's as a project addressing gender-based violence, we also focus on interpersonal contact. So if we can move on to the next slide, please. Yeah, so on the impact of COVID now and enriching and delivering services to our targeted population, the community members are now shunning to access services in fear of contracting COVID. You saw from the previous slide, the picture of a small group discussion that had a lot of people participating in the dialogue. But in this picture, we can see that we have reduced to very limited number for interpersonal contact. We also have been facing difficulties to mobilize community members for dialogues and awareness meetings. And then the other challenge of COVID in relation to access to justice was the court sessions that were halted, and priority was only given to the criminal cases. So we saw most of the GBV cases not going through the courts of law. Next slide, please. In terms of the programmatic solutions to COVID-related challenges, so as a project, we've adapted the use of the toll-free hotline to provide telecounseling and refer survivors to other service providers. In this also, we are using community radio station as a part of non-contact communication to raise awareness on COVID prevention and GBV prevention, as well as provide information on where people can access services. We also have leveraged on influence of our traditional and faith leaders to sensitize their communities, even when there is no contact and the use of technology. So the use of WhatsApp and other social media platforms. In the picture there, you can see that's a traditional leader who is having a community meeting and in the context of COVID. The last point that I'll talk about is the training that we've offered to the one-stop center staff on COVID prevention and provision of safe and timely GBV services. And we have also provided prevention commodities for the one-stop center staff. Next slide, please. Yeah, thank you very much. So in conclusion, how we are tracking and monitoring these programmatic shifts and results. So there in the picture is a snapshot of our tracking tool, which is a week-by-week tracking for the GBV cases that are recorded at the one-stop centers, Childline, Lifeline, and the Zambia Police. So we are tracking that on a weekly basis. So observing weekly trends in terms of the decrease in the uptake of services, this will help us to adapt to community mobilization strategies that will address the impeding factors and to accessing services at the one-stop center. And then the second item is that the one-stop centers have dedicated data entry clerks to provide the timely data. We have also collaborated with other partners partners in the GBV, in the gender and GBV sector to determine and establish best practices. This is the end of my presentation, and many thanks for listening.
Great, thank you so much, Doreen. That was an excellent presentation and really helps us to understand how your organization has been so innovative in adapting to the challenges that COVID-19 has presented. And I would say it's a great opportunity for our webinar participants to please feel free to put questions into the chat box for Doreen to ask more questions of her about the work that they are doing. It's a really great opportunity that we have her here today, and so want to make sure that we give you all a chance to ask her more questions as needed. We are coming towards the end of our formal presentation, but in closing, we wanted to share a compiled list of additional technical resources for you. Next slide, please. So this slide, these resources include the USG policies that Emily talked about earlier, including the PEPFAR gender strategy, the USAID gender equality and female empowerment policy, and the US strategy to prevent and respond to gender-based violence globally. We've also listed some key technical resources from WHO that inform our work and that would also be, I think, of great interest to you all as well. We've seen many requests for these slides today, which will be sent out. And we will also add in links to some of the child-specific resources that Emily was mentioning earlier, in particular, the WHO clinical and policy guidelines for children who have experienced sexual abuse, as well as some of the training resources on training providers on how to provide both clinical care and first-line support for children and adolescents who have experienced violence. Next slide, please. Great, so I think now we will move into the final set of questions and discussion. Thank you very much.
Right, thank you. The first question is, do we use different approaches in GBV clinical inquiry and GBV screening, or it's just semantics?
Yeah, that's an important question, and that yes, they are different but related approaches. A clinical inquiry approach involves looking for signs and symptoms of violence. These common signs and symptoms are documented in the WHO clinical and policy guidelines and the clinical handbook. So the idea with clinical inquiry is that healthcare providers are trained to identify these signs and symptoms and be able to ask follow-up questions of that individual. The routine inquiry approach is where you would have a service whereby a provider would automatically ask someone about their experience or fear of violence. They might be trained in identifying signs and symptoms, but part of the protocol of providing that HIV-related service is to ask questions about violence. Most commonly, the way this is done right now is in HIV index testing and partner notification services, whereby individuals who test positive are asked to provide a list of their sexual or needle sharing partners. However, when doing that, it is standard procedure to ask about fear or experience of violence from any of those named partners, regardless of whether or not any signs or symptoms of violence have been identified. So those are the main distinctions between clinical and routine inquiry.
All right, thank you. Next question, may we please have the experience of Zambia during this period of COVID-19 on communication in order to reduce violence effect? Because there are areas without radio, telephone in Africa, and some countries, for instance, in DRC.
We pass that question to you.
Can I take the question?
Sure.
Yeah,
sure, go right ahead.
Yeah, in terms of our communication during this period, the COVID period, really, we've seen that radio, use of community radio stations and airing the programs has been really effective. And I should say that for Zambia, luckily in all the 16 districts that we are operating in, we have at least some radio in those districts. So we've used that platform really in terms of the communications. But also, we have also used the social media platforms for the faith leaders and the traditional leaders. So they use WhatsApp groups, they have formed WhatsApp groups for their communities as well as for their churches, and they use those platforms to disseminate information.
Thank you. Somewhat related, can you speak to church organizations that do not talk about contraceptives? What could be done about this?
Is that a question that was posed to Emily and myself, or is that a question for Doreen?
For a general question for anyone.
Okay, great. And could you repeat it once more just to ensure we've got it?
Absolutely. Church organizations do not talk about contraceptives. What could be done here? We can also answer that after the webinar on Q&A.
Sure.
Hello? Can I take a stab at it?
Sure, please go ahead.
Yeah, I think for the churches, we are using the Faith Communities Initiative to come up with messages of hope based on facts that can be shared with these faith-based organizations and the churches. You know, for now, I think once we use facts, yes, scripture has certain information that they're supposed to follow, but we are providing facts based on scientific evidence. Maybe Doreen could speak on the progress we have made with the Faith Communities Initiative.
Over to you, Doreen. Doreen, you're on mute.
Hi, sorry, I was having some technical challenges with my laptop. Yeah, thank you very much, Chipo. Yes, so we are also implementing the Faith Community Initiative. And in terms of disseminating messages, we have been using the messages that were developed and shared and using the platforms in the churches. And those messages, the churches adapt scriptures that talk to those messages, and that is how the messages are disseminated. So they attach scriptures and share. As they're sharing the message, they also talk about the scripture that talks to the message.
Thank you. Next question, a general question for the presenters. GBV data isn't reported or captured by a TB program. How can this indicator be monitored within the TB program?
So great question on TB. If this is a PEPFAR funded program, we can speak more to the PEPFAR funded program as opposed to programs that have funding from TB or other sources. Essentially, what you would want to do is, if you have sites that are providing clinical care and treatment for HIV and for TB, you would want to identify if that site is able to meet the minimum requirements of providing post-violence clinical care and being able to conduct clinical inquiry. That's the first thing that you would want to do, is to do that kind of assessment, because we don't want to ask sites and facilities or partners to provide these services if they don't have the training or the necessary equipment or ability to capture the data. So that would be the first thing to do, is ensuring that those minimum requirements can be met. The second thing you would want to do is have a conversation with that site and understand how the provision of care could be integrated as part of their routine health service delivery, how the use of clinical inquiry would be integrated into TB and HIV care, and then what that patient flow and that service delivery would look like. So there's a lot of those kind of important steps that would need to happen first before you would want to consider going forward and saying, okay, we need to do all of this post-violence care service delivery right now. So those preliminary steps of ensuring that the minimum requirements can be met really are essential.
Thank you. Do you have guidelines, standards, or caveats for partner notification services?
So PEPFAR has released a series of guidelines and documentation on index testing and partner notification. Those were released somewhat recently through the Office of the Global AIDS Coordinator. If you are an organization that has received PEPFAR funding to conduct index testing and partner notification, we would strongly recommend that you be in touch with your with the prime implementing partner or with your USAID AOR or COR to receive those guidelines and to have a conversation with them about what those guidelines mean and how they should be implemented in the index testing and partner notification service delivery. So please do be in touch with your prime partner and your USAID mission focal points and staff, your AOR, for those resources.
Thank you. How does one-stop center work? Do you use toll-free line where people can report cases and are supported?
That's a great question, and actually I think that would be a great question for Doreen, if you're able to talk about that based on your experience in Zambia of one-stop centers. Doreen, would you be willing to answer that question?
Sorry, could you repeat the question?
Sure. How does one-stop center work? Do you use toll-free line where people can report cases and are supported?
Okay, thank you very much. That's a very good question. So one-stop centers are a facility based at a health facility where survivors can access all the services that they need in one place. So at a one-stop center, you find there's a medical personnel, there's a paralegal, there's a police. Here in Zambia, we call them victim support unit. There's a data entry clerk, and there's a psychosocial counselor. So in terms of how they work, linking the toll-free line to the one-stop center. So sometimes the hotline that is being operated by Childline Lifeline do receive calls, and they refer these survivors to the one-stop centers. Then they also communicate with the one-stop center coordinator and provide the necessary details for the survivor. Then the one-stop center is able to follow up with the survivor, and then the survivor goes to the one-stop center, or sometimes they are picked, and then the service is provided to them. So it's like a bi-directional referral kind of thing. I hope that answers the question. I hope I got the question correctly.
Absolutely, thank you. Our next question is, how do you measure the programmatic index for human participation? For instance, people reached by sensitization through radio programs, IPC, and community stakeholder involvement.
Mm-hmm. Yeah, that's a great question. We do have a whole series of custom indicators that measure all aspects of GBV prevention programming, as well as programs and activities that address gender inequality and harmful gender norms. There was a very good resource that was produced by Measure Evaluation several years ago now that has a compendium of validated indicators that can be used to measure exactly that: communications programs, outreach, and things like that. And we'd be happy to include that resource in the final slide deck that we send out to all participants.
Thank you. A few more questions. The next one is for you, Doreen. You sort of answered it, but I'm gonna read it for you. So what pages do you have to, what processes do you have to ensure prompt referral for post-GBV services, especially for those indigent and those who cannot afford to pay for these services, or even issues of logistics for those in hard-to-reach locations?
Thank you very much for that good question. So in terms of the processes that we have, I should mention that this Stop GBV project is a follow-on. So there was a predecessor project that established the one-stop centers. So at the time of establishing the one-stop centers, one of the things that they looked at was, in terms of the logistics, was the transport. So they actually provided vehicles, at least a vehicle for each one-stop center, for the one-stop center to be able to follow cases in the communities. So what happens is that we have this Stop GBV follow-on project has taken that on board. So we have that dedicated vehicle for the one-stop center, and it's fully managed by government, that's Ministry of Health. And when there's a case in the community, the one-stop center staff called, and they go in the community together with the police and the full team to go and pick the victim and start the process. I hope that answers the question.
It does, thank you.
Yeah, maybe I should also mention that other than the communication, also that the project is providing, more especially in this COVID context. So we want to we want the one-stop center coordinator to have that constant communication with the communities, so that the communities are also able to call the one-stop center directly or the police directly, and the one-stop center responds by sending the team to the community to go and attend to the case. So we are also providing a little bit of communication in terms of talk time for the one-stop center to be able to move quickly. But this is just in the context of COVID.
Thank you. So next question, knowing that community collaboration and cultural respect is important for sustainability of the program, how do you expect to integrate the child protection rights without being culturally insensitive?
So yeah, thank you very much for the question. I think that there are some very good resources available that talk about preventing and responding to violence against children. In addition to the ones that we have mentioned today, there's also a really great website called Together for Girls. They are one of the partners that implement the Violence Against Children surveys, and they have a lot of great examples of communications campaigns and messaging around violence against children. So I would really encourage you to go and take a look at some of those materials. And we'll also ensure that we send out links to those resources when the final slide deck is shared.
Thank you. Next question, does USAID provide the training for service providers, and how can an organization access this training? And a sort of a related question, is it not critical to train first-line responders, help-line workers on how to respond to GBV?
Mm-hmm. Yeah, thank you. That's a great question. And the training really is so critical. Before any organization or site gets involved in GBV prevention or response work, it's really critically important to ensure that everyone is well trained, not just in the provision of services, but an awareness and understanding of the structural issues that are at the root and that cause violence. I would certainly encourage any organization that is interested in receiving more training and more technical support. Please do reach out to your USAID mission contacts, or if you are a sub-partner to a prime partner, please do reach out to them, and they should be able to provide resources or give some kind of idea or direction as to where that kind of training, further training and capacity building could be accessed. So please do contact your in-country colleagues and resources, and they can help connect you to additional training and technical assistance.
Thank you. Our next question is, how should one assist women suffering from violence and HIV during COVID-19, because there are transport challenges and also challenges concerning drugs and equipment?
Yeah, so the COVID-19 environment has really posed a lot of challenges to being able to reach survivors in a timely manner, or for survivors being able to access services. Every country has had a little bit of a different experience in this. We have a lot of our partners throughout sub-Saharan Africa have done some really terrific work throughout Zimbabwe and South Africa. Our partner today, ZCCP in Zambia, they have great examples about how they've been able to reach women who are experiencing violence. Several weeks ago, actually, we hosted a webinar that featured 7 of our local partners throughout sub-Saharan Africa, including South Africa, Zimbabwe, Uganda, Tanzania, and Liberia in West Africa. And they all shared their experiences of providing GBV services during the COVID-19 period. And I think we should be able to share the slide deck that was presented from those partners that was presented during that webinar. And I think we can probably include that in the resources that we share at the end of this presentation. I would say there's also, there's been a lot of publication of some really good evidence and experience being shared. Certainly our partners throughout the United Nations have been pushing out a lot of different content on that, but also a lot of international non-governmental organizations have also been talking about their experience and their approaches using a variety of methods, such as remote case management, reaching survivors using different communications channels. I think Doreen gave some excellent examples of that. So we're starting to see a lot of really good and innovative ways of reaching individuals during this period. So we'll try to add some of those additional resources into the slide deck before we get it sent out.
Thank you. Two related questions. Can you disclose what is comprehensive services for a survivor? What are the elements included in this? And then somewhat related, when survivors present their physical injuries, how do we provide medical services since we only provide PrEP on USAID funded project?
Sure. Emily, do you want to go back to the slide that had the minimum elements, and do you want to talk about that a little bit?
Sure, and please let me know if I don't answer every component of the question. So this is the minimum package of post-violence clinical care services. And this minimum package is defined by WHO and PEPFAR. So this is the list of comprehensive clinical services that must be available for a survivor of violence. In order to report on GEN-GBV, all of these services need to be offered at a site. If a site only provides, for instance, pre-exposure prophylaxis, PrEP, then that site cannot report on GEN-GBV. What that site can do is conduct clinical or routine inquiry within PrEP service delivery, which means identifying survivors of violence. When an individual who is experiencing violence or who fears violence is identified, then that site that delivers PrEP can offer first-line support using lives. And again, first-line support, I'm gonna go back to that slide as well. First-line support is the immediate care given to a survivor when they disclose experience of violence or when a provider suspects that they are experiencing violence. So a PrEP site can provide first-line support, which again is really just listening empathetically, inquiring about their needs, validating what the survivor is saying, ensuring their safety and helping with safety planning if necessary. And then the S in lives, the provider should refer the survivor to local GBV response services. The services that the provider should refer to at that PrEP site should be services that offer, or excuse me, organizations that offer non-clinical GBV response services, as well as sites or facilities that offer these comprehensive clinical GBV response services. So again, if you are at a site that does not provide all of these services on the screen, such as your site that offers PrEP, you can identify survivors of violence, provide first-line support using the lives approach, and then refer them to sites that offer GBV response services, including clinical GBV response services that do provide this full minimum package.
Thank you. Two somewhat related questions. Do you have a child protection committee at community level? I think this is for Doreen. I repeat, do you have a child protection committee at community level? And how have they supported GBV prevention, identification, and referral for post-GBV care during COVID-19 period? Also, the second question, do you have data and structured GBV programs for children with special needs? Doreen, do you want to take the first one? You're on mute, Doreen.
Yes, sorry, I was having a challenge with my laptop. Yeah, it was constantly locking and I was not able to unmute. Yeah, so we do have child protection committees in most of the communities that we operate in. And what we've done as a project, actually, we've gone in those communities to train them on SVAC prevention and response. So we are trying to form a response team at community level that is going to work with the one-stop centers and other stakeholders in the district to manage all the cases at district level. The second part of the question was, how do
you have data and structured GBV programs for children with special needs?
So we do not have any structured program for children with special needs, but what we've done as a project is that we are including people with disabilities. So we are also targeting for children specifically, we are also targeting the special schools. So these are the special schools where the children with disabilities go to. But also at community level, we are working with the Ministry of Community Development that oversees the component of disability at national level, from community level to national level. So with having a social welfare office who's under Ministry of Community Development at the community or district level also helps to also bring in the children or the families that have children with disabilities onto the project. Thank you very much.
Thank you, Doreen. Our next question, what should be the strongest link between OVC community program and ART sites on GBV prevention and response services in terms of clinical and non-clinical GBV care?
Sure, that's a great question. I can answer it briefly, and then we may just need to follow up in writing with some additional responses. I think we'll want to talk with our OVC colleagues as well about that and get some references from them. Essentially, for our priorities, what that looks like is that for any children that are identified in the community, for example, through a community caseworker or a social worker, a case management structure, that any children who are identified there have some kind of referral, particularly a warm referral or an escorted referral to clinical services who may be needing it. That's what we want to ensure is happening there, as that connection is made. In the same way, for children who might be seen, who are, especially for children living with HIV, who are being seen at a facility, we do want to ensure that their other non-clinical support needs are being met. So we want to ensure that strong linkage between the facility or the clinical service and some of the social work, the case management, the non-clinical services are there, just to ensure that those children are getting all of the services that they need to support them. So that's the priority that we're talking about there. But I would also refer you in particular to other OVC technical guidelines and priorities. Please do reach out to your USAID points of contact in the countries where you are, and they can provide additional technical guidance as to how children experiencing violence, particularly children living with HIV, should be connected to other OVC programs and services.
Thank you. We have realized that once VAC is incorporated into GBV, it loses its importance. For VAC, the children are protected by statutory laws, including Child Welfare and Protection Act. We have seen cases of children not being reported for violence response interventions. How can we best ensure that authorities are aware of the difference of the two?
So my understanding of the question is ensuring that local authorities and organizations are aware of the specific laws around child protection and mandatory reporting. If I'm understanding that correctly, again, that gets to a very kind of a country-specific issue and what the different laws and policies may look like. I would, again, strongly recommend that you reach out to your USAID OVC technical advisors and other other OVC implementing partners to talk about those specific laws and policies and how they are implemented in the particular country where you are working.
Thank you. If a partner has to report on the indicator of GEN-GBV, but STI treatment and treatment of injuries do not exist on the PEPFAR sites, but PrEP exists, will the partner still not report the survivors accessing PrEP data?
Emily,
So,
go ahead.
Sure. So if I understand the question correctly, it's saying that if treatment of injuries and STI are not supported by PEPFAR at a site, but PrEP is, how does that reflect reporting for PrEP and I'm assuming reporting for GEN-GBV? I'm going to go back to our minimum package. So first, for GEN-GBV, if a site does not treat injuries, if a site does not provide STI testing or screening and treatment, but does provide all of these other services, that site cannot report on GEN-GBV. We do, however, encourage that site to work with their country team to report on a custom indicator so that we can keep track of the GBV response services that are being provided, but that site cannot report on GEN-GBV if that site does not provide every single service listed on this screen. I want to be clear that post-exposure prophylaxis, PEP, is part of the minimum package. Pre-exposure prophylaxis, PrEP, is not part of the minimum package. If a site provides PrEP, that site should report on the PrEP-MR indicators. PrEP-NEW, PrEP-CUR, and any other custom indicators in relation to PrEP, pre-exposure prophylaxis, that site is required to report under. If that site does not provide every service listed here on this screen, that site cannot report on GEN-GBV. So again, really also just want to be clear that PrEP is pre-exposure prophylaxis, and for post-violence care, we're talking about PEP, which is post-exposure prophylaxis.
Thank you. Do you have any guiding tool on how to identify individuals at risk of GBV at community level?
Okay, that's a great question. And so I think it's important to note that the USAID priorities and technical priorities and strategy, we're very clear about the fact that community organizations should not actively go out and try to find survivors of violence. What we do say is important is for organizations working in the community that they should be prepared in case someone that they are working with in the community voluntarily comes to them and discloses their experience of violence. If someone voluntarily comes to them and discloses their experience of violence, that organization needs to know how to respond and what to do. They need to know what that first line response is, that emotional care, that compassionate reply, and then where to refer the individual to services. We do not think that community organizations should go out and actively look for cases of violence, frankly, because the quality of doing that could be compromised, and the evidence has shown that this is not an effective way to reach survivors. It is important to have community messaging about the harm that violence does, and having messaging about where services are available, and having messaging about how it's not someone's fault if they're experiencing violence. But to repeat, community organizations shouldn't actively go out and ask individual participants if they have experienced violence. What they do need to do is ensure that if someone voluntarily discloses to them, that they're able to know how to respond and to refer. I hope that helps to clarify that question.
Thank you. Are those projected estimates of IPV when the COVID-19 outbreak persists based on current data on IPV? And are there global reports on IPV so far during COVID-19?
Mm-hmm. That's a great question. And these estimates really are based on what we know right now about the global prevalence of intimate partner violence. Remember that intimate partner violence, the data that you will see in these kinds of global surveys done by WHO or the Demographic and Health Survey, remember that those are probably very low estimates, because not everyone is going to disclose that they are experiencing violence. These are very, very good surveys. The methodology is sound, and we absolutely rely on them for our estimates, but we do know that they are still low just because not everyone reports. And so the data that you see here on the screen, these are estimates of the additional cases that we might anticipate seeing just based upon what we know about the lifetime experience of violence, particularly against women and children.
Thank you.
Mm-hmm.
Maybe a few more questions, looking at the time. There are some communities that are so quiet about GBV. In fact, some feel that it is part of culture. This can make it difficult to do IPV inquiry. Do you have any strategies that could be used to conduct proper IPV in some communities?
That's a really great question, and thanks to the attendee who provided that. Yes, talking about violence is an extremely difficult and sensitive issue, and there are ways to talk about it that are culturally sensitive. We don't have a lot of time to go into all of that today, but I think using a couple of different approaches is important. There is the approach of using different kinds of communications campaigns and messages to start raising awareness of violence, particularly the health-related harms that it does to children and to women and to families can be a very good way of talking about and starting to increase the sensitization. Another important way is when individual providers are providing care to clients is to be familiar with the language that is used in that community when talking about violence. So for example, a lot of women might not like the term violence against women or even the term violence because it wouldn't necessarily be recognized as violence. And so what's important is for providers to understand how in that community are these issues talked about, and to use that kind of language, use that kind of terminology as a way of bringing up the topic with their patient, with their client, particularly if they have observed some of the signs and symptoms in that client that they might be experiencing violence. And so that's a really important way of how to do that at an individual level, but also thinking about ways at a community level to start increasing that sensitization. It's a great question, and unfortunately we don't have too much time to go into detail about it today, but thank you for raising that.
That's the end of our Q&A session for now. I'll hand it over back to you.
Great. Well, that gets us to the end of our presentation. Thank you all very much for joining us today. We really appreciate having the opportunity to share these resources, to share USAID's technical priorities and approaches. As the organizers mentioned, we will be sharing these slides and updating them with some additional resources that you all have requested. And of course, please do feel free to reach out to us if you have additional questions. Our email addresses are there on the slide. Thank you also very much to Doreen from ZCCP for being with us today. We really appreciate your time and all of the expertise and sharing what you have been able to do in Zambia, particularly during this very difficult COVID period. So thank you so much to Doreen and ZCCP. And thank you all, and we hope that you have a great rest of your day.
Thank you, Amelia. From ASAP, we would like to thank Amelia Peltz and Emily Rattenauer, and Doreen Manda and Lauren Murphy and Chipo Tembo for organizing and participating in this webinar. Thank you all to our participants and for everybody who completed the poll. Thank you and see you next time. Bye-bye.
Thank you. Thank you. Ah.